Hello, my name is Sarah Wack, and I'm a student at the University of Buffalo and the Summer Education Intern with the Jacobs Institute. I'm excited to welcome you to the Jacobs Institute's High School Webinar Series. The Jacobs Institute is a medical innovation center located on the Buffalo Niagara Medical Campus and sponsors collaboration between clinicians, researchers, engineers, and entrepreneurs to develop medical devices. Over the course of 4 webinars, our host, Dr. Ken Snyder, will discuss the ever-changing world of medical practice with emphasis on how different interests can collide to create new innovations. Dr. Snyder is a dual-trained neurosurgeon and a part of the University of Buffalo's neurosurgery department. His additional training and specializations has helped given him the necessary tool set for specialization in the comprehensive management of neurovascular pathology in both the brain and spinal cord, including treatment of aneurysms and stroke. Also joining today's webinar panelists is the Jacobs Institute's high school representatives, Janat and Josh. Janat is a rising junior at Public School 197, Math Science Technology Preparatory School, and Josh is a rising senior at St. Joseph's Collegiate Institute. This webinar series is aimed to help provide insight into the fascinating world of medical practice and help start the discussion about the technological advancements happening right in front of us. At the conclusion of the webinar series, participants will have the opportunity to enter their name into a drawing for a chance to attend a smaller Zoom meeting with Dr. Snyder at a later date. In order to enter the drawing, participants must have attended at least 3 of the 4 webinar sessions. At the conclusion of today's webinar, a link to a SurveyMonkey will appear. Please fill out the survey. This feedback helps us make adjustments and improvements to the webinar experience. Questions and comments are encouraged. Please type any questions you may have in the chat box on Zoom during the webinar. Questions will be raised when relevant during lecture or answered during the Q&A section scheduled in today's program. Please keep all questions and comments appropriate and respectful. There's also a voluntary discussion opportunity for those who wish to connect with other attendees outside the webinar series via Yammer, a professional social networking platform. With this platform, participants, if they choose, can continue the discussion with others and help foster a community of shared interests. Attendees will receive an automated email from Yammer, inviting them to the group page shortly after the webinar. Without further ado, I present Dr. Ken Snyder.
Thank you. Thank you, Sarah. Thanks to the JI. Thanks for the panelists. Thank you all for taking an hour out of your day to spend time with us in the summer to learn about what we do every day. And this is your time. Again, I look at this as a piece of clay that we're going to evolve together. We can take this in whatever direction the collective group would like to go in terms of learning about technology and innovation in medicine. I have some general ideas, but this is actually your time, and I want this to evolve that way. I often speak to my old high school group by starting out saying, who's the oldest person in the room? You know, and the seniors might say they're 17 years old. And I usually tell them, I've been in training after college for older than you're alive. It took me 18 years of schooling to get my PhD in physics and biology, my medical degree, my training in neurosurgery, and the 2 fellowships that I've had. So it's about time I got a job. And the one beautiful thing about it is I never stop learning, and the excitement of what I do every single day, it is something that I wouldn't have changed any of what I've done in the past to get to where I'm at. I also have had a neurosurgical mentor that has said, I don't care how many years of training I've done, to save 1 life is worth it all. And we are blessed to do what we do. And hopefully we'll give you a glimpse into something that you wouldn't have the otherwise an opportunity to see. I like teaching high school students from also concepts of TED Talks. And I think that those are important because TED Talks have a little bit of a formula to how they work. It's the importance of telling stories and how we interact with each other through storytelling, and how we remember things through storytelling. It's the importance of, in 15, 20 minutes, how do you reduce what you want to say to that time frame and nothing more? How do you think about the theme of what you want to get across and come back to it a couple times while building on it so someone really remembers what you're telling them? And how do you tell a story without note cards, right? I mean, part of the importance in anything that any of you decide to do is having the emotional intelligence to deliver a great talk. Doesn't matter what field you go into. And TED Talks really can give us some of the tools for that. And so as we go through this, I'll keep coming back to some of these themes or the reasons I shared them, because I think there are some important things to the refinement of doing it. Suzuki teaching for music is a beautiful method. The method is start with learning the notes, put the mechanics of the notes into your cerebellum and into your mind, but then you actually begin to learn to play the piece. The art comes after you've memorized it. And I think there's an important learning aspect to that we should take into any career we go into. I shared with the group an important talk called Start With Why. And the reason I think it's important is because it flips upside down the way we typically think about things. And I think it's something that each of you should be thinking about as you move through each of your own career paths. I have the opportunity of interviewing some of the highest trained individuals for the most premier fellowship in the world in vascular neurosurgery. And I will tell you this, I usually know in 5 minutes whether this is someone that's going to make it or not. And usually what it is it's not their scores, it's not what's in their resume and other things. It's the passion that they bring and the uniqueness that they bring in how they tell their own story. As I look back to where I was in high school and thinking about what my application needed to look like and what I needed to say in my interview, I made the mistake of imagining someone was looking for something that I needed to become, instead of thinking, who am I? Who do I want to be? It is a critical learning point for you. You're at a beautiful time in your lives to start flipping that switch. You will have a completely unique path ahead of you. And that's the story you're telling. What do you want your story to look like? Unfortunately, I see a lot of people pass in their lives in my career. And I have to tell you, one of the saddest things I hear from people when they're passing is that they wish they had done something else. You are at a beautiful time in your life. Do not allow yourself to have that statement. Live with the passion of doing what you love to do. Make your career your hobby. I know these are high wish lists, but you have the ability to do that. One of the other things is that doesn't mean that you just get to say, I don't care to do anything. There are things you're going to do what you don't feel like doing or want to do. The challenge to you is, can you find a way to understand why that might be relevant? I can't tell you how many times I sat to learn something and said, I'll never need to know this. And sure enough, there was a patient in my life that drove that home, that if I hadn't learned it or I wished I had remembered it, it would have made a bigger impact for. This is a basic outline of what we may cover over the next 4 sessions. There's a lot in here and we can take it in any direction, but this is actually based on a lot of the feedback that almost 50 of you have given coming into this in terms of what you want to hear about, what you want to talk about. I'm going to start with innovation and aneurysms because I think it's the easiest to appreciate the innovation directly in terms of the image of how it impacts the vascular system. Then I want to talk about some basics of physiology of the entire body. That doesn't matter what facet of medicine you go into, the core principles are there and important. I want to talk about stroke because the entire paradigm of how we treat stroke has changed in our lifetimes. In fact, in the past 2 years. I then will talk about COVID, since it's so relevant to all of us and how it changes how we will treat medicine moving forward and just innovation in general moving forward. There are some principles that the juniors, seniors, or first years in college may start to appreciate that I want to bring up to the entire group. And this involves the ability of moving from a time resolved sequence to a frequency resolved sequence. They're called power spectral analysis. It also means, taking a deterministic outcome and what does it mean to think in terms of probability and how does that affect us? The biological system is not deterministic. There's this thermal bath of everything shaking. And what does that do for the outcome? It's a whole different way of processing or thinking about things. And it really relates to how the brain breaks up information and processes it. Another thing I'd like to talk about is construction, deconstruction, how this relates to microelectrical mechanical systems and 3D printing. When we want to build something, do we take a block and chisel it away? or do we take a small scaffold and build to our final product? And how do we take advantage of biology and science to do either of those? People commented on they want to learn more about research, how the brain works, developments, neurology, and fields of medicine. We should be covering all that as we talk about all the different topics. What's going to be critical is that our panelists interrupt me, because I can end up on all kinds of tangents. I really want this to be as interactive as possible. Please submit questions. The panelists will be reviewing them and we'll talk things through. We at the Gates Vascular Institute, and that's what this building is in front of you, are fortunate enough to have built the entire building to be a wireless and a Wi-Fi display of our surgeries that we perform. 6 times a year, we open up our doors and let sometimes 5,000, 10,000 people at a national conference watch us perform a live case. And each time that we do this for the world, we put a short video out, and this is the video that we use going into the live case. So that's the Gates Vascular Institute. That's my partner, that's myself, that's my other chairman and partner. We're all dual trained neurosurgeons. That is an angiogram suite. I want to show you what that looks like. So an angiogram suite is an X-ray, it's a machine where we do surgery with X-rays. So we wear lead and protective equipment while we're in the room. The angiograms are actually dye that show up on an X-ray, and that's what's on those screens there up on the monitor in front. Those are pictures of the blood vessels. Those show up because the X-rays move through and bounce off of those because of the dye that we put inside blood vessels. So this is what the surgical room actually looks like. And we access the blood vessels through literally a needle puncture. So the entire surgery is done from the groin of a blood vessel. Then we move through the blood vessel system like road maps up into the head or a different body part to do surgery. I'll keep showing the rest of this clip. So one of the other gentlemen in this picture, Dr. Hopkins, he actually was one of the original pioneers to invent this field. 20 years ago, endovascular surgery didn't exist. It's now a core fundamental of how we learn to practice medicine. But going inside the blood vessels and being a glorified plumber wasn't even in existence for neurosurgical technique. He, our mentor, the originator of this building, actually built the tools to do the work that we do right now. So one of the other things that you're looking at here, that the students that get to visit us, and hopefully each of you will find some opportunity to visit us as things open back up, is that we have learned that we can learn our techniques without having to do it on people. Much of what we learn from an apprenticeship in medicine is trained through actively learning on individuals. We would have apprentices and a master surgeon teaching a junior surgeon, and that other would be watching us as we work, and then they'd work their way up to the table and do it themselves. We now have simulators and flow models, and those have transformed anything. It allows a high school student to come in and do 100 carotid surgeries or do aneurysm coils. But our ability now to use this tool to train surgical technique is exceptional. It's one of the benefits that we have here, and it really has helped us improve our technology and technique. So here we're performing surgery on 3D models. And what we can use is the custom anatomy of our most difficult cases to actually build the 3D models and practice, or use them as practice tools for students and others. So the last part of that clip showed some of our live case presentations. The actual building itself, the JI is in the middle of the building. The upper 4 floors are all research. So many of you bring many different aspects of interest. There are X-ray engineers. There are computer scientists that specialize in 3D modeling. There are fluid dynamics specialists. There are biology and microbiology specialists that want to learn about blood and the bloodstream and other things that could happen inside blood vessels when we treat disease. All of that research lives in the 4 floors kind of above this building. In the middle of this is the Jacobs Institute, where we have all of the training and education. And underneath this is where we do all of our clinical work. So I might go from the emergency room to an operating room to an angio suite, and then up to the JI to talk or teach, and then have the researchers above us. Having all of that in one building is what makes this place so unique and so exciting to work in. And again, everyone that spends time on this high school webinar becomes part of the JI family. They're able to shadow and watch cases. I often do letters of recommendation as we build relationships and do projects. But the idea is to inspire you to come in with some ideas and work collectively with this group. I love hearing from the students that 4 years ago, 6 years ago, were in this program and still come back just to brainstorm around ideas or tell me what they're up to now. And we all celebrate each other's success. The small groups, when we work together, what was nice was one of the important things in learning is being able to learn together. I think being able to interact with each other respectfully, but yet challenge one another is a critical facet of learning that we don't necessarily appreciate in a formal classroom. The ability to listen to one another's ideas, but then refine someone else's idea, potentially, but also to not think you're the smartest person in the room. I mean, you need to realize you can learn from anyone around you if you allow that interaction. And so again, hopefully Yammer or some of the chat allows us to do that. But what I loved about the small groups that we would do at the JI was by the 3rd session, I wouldn't even need to be teaching. I would be watching the students interact with one another on a topic, and then I knew we're in the right direction. It also, yeah, please.
We have a question about the protective gear that you wear in the angio suite. Could you go into more detail about that? Is it difficult to work in that?
Yeah, it's a great question. And the stuff that I used 20 years ago was so heavy. So there's lead gowns and aprons, lead gloves, lead shields. And so some of the newer technology is still lead, but it's come up with ultra thin technology. Also, an interesting mistake we used to make was that we would use lead protective gloves. But then we actually did studies of putting the dosimeter inside of our hands and putting the gloves over. And what would happen is the x-rays would be bouncing in between the gloves so long rather than just penetrate through that we'd have higher dose to our hands. One of the hard things about this field before learning this was our generation before me ended up with severe cataracts, crippled hands, or other problems because we don't realize the amount of dose of radiation we might be giving, not just ourselves, but again, our patients. One of the really cool things we have uniquely here is a real-time dose meter, not just for ourselves, but for our patients, so that we can tell if we're delivering too much radiation along a specific track and can modify it. It's a great question on ergonomics. We check every single physician that's in the room with treatments by badge, and if they start to hit a higher level of radiation, they're actually not able to perform surgeries. It's a great area of opportunity for conversation. Or for innovation and ideas. One of the other thoughts that this made me bring up is, again, high school is a really important time to flip the switch of you are your own teacher. It doesn't matter how good or bad the teacher of the course is. You should be able to teach yourself anything. Between YouTube, Khan Academy, pick up a book, interact with somebody, if you start to realize you are in charge of your education and learning, it opens a whole nother frontier and opportunities for you. Don't blame anyone else. And so that what does the teacher become? The teacher becomes you bring your questions to them of the problems that you've had. The sooner you do that in your career, the better, and the faster you will find yourself moving down the track of your learning. All right, I wanted to cover aneurysms in about 10 minutes, just some ideas and innovations. So aneurysms are, again, think of the blood vessels of the body like tubes. If there is a weakening in one point of the tube, there can be a balloon or outpouching of that wall, and those can take different shapes. There could be a small weakening that leads to a circular bleb. Those are called saccular aneurysms. Those are usually aneurysms that happen by flow direction. So for example, if this is a blood vessel that normally comes together like a T, and the blood flow comes up like this, a flow-directed saccular aneurysm usually looks like that. It's directly in line with flow in these blebs. And that's the most common type of aneurysm. The other is what's called a fusiform aneurysm, or a dissecting aneurysm, where it's the length of the blood vessel that has ballooned itself out. And that usually happens from a tear in the blood vessel. Blood vessels are actually made up of multiple layers. There's an inside layer called an endothelium, and that turns itself over every 5 to 7 days. Remember, blood vessels are living tissue. And in the inside is a more muscular, meaty layer, and then the outside is where the blood vessel gets its own blood supply from, called the adventitia. And you can have a tear of the blood vessel wall, and blood can rush into the wall itself to create an aneurysm. The blood vessels live outside the meat of the tissue. So when I think of the blood vessels of the brain, I like to describe them like a tree. But what's interesting is the tree trunks live outside the blood vessel. So when we look at the brain and we look at the major piping blood vessels that come up, these are the carotid arteries here and the vertebral arteries here. The blood vessels travel outside the folds of the brain. So when you want to do work or do surgery to get to the blood vessels, you don't travel through the brain to get to them. You find your way through the folds of the brain to get to them. Does that make sense? The other interesting thing about the tree is the importance of these penetrating type of blood vessels. So again, if we thought of the blood vessels like a tree with branches and the leaves or the brain tissue, there's lots of really important twigs that go to really important leaves all the way up. So if it's a tree with a lot of small branches to it. So if we were going to fix one of these aneurysms, the tried and true method for doing it is to open up the brain, look at the aneurysm, and seal the two ends of it together with a clip. And so some of the requests that came through were, I want to see surgeries. So I thought I'd open up the gate again with something that you may not ever get to see, which is a brain surgery for a clipping, and just show you how beautiful the brain looks like and what we do. And maybe with each of these opportunities, I'll pick a different type of exposure or surgical technique that we go through. So basically, to do the vast majority of our surgeries, we do what's called the terional craniotomy. We shave a portion of hair on one side that we'll be operating from. We put an incision behind the hairline, so when the hair grows back in, you wouldn't see it. We peel the skin forward down to the eye from that incision, and then what we're looking at is the skull. We drill 3 holes into the skull, and then we do a surgical cut to remove it. And when we remove it, you remove it in a way such that it's beveled, so that the outer part of the skull and the inner part look like this. So when you put the skull back in, it doesn't pop all the way through, right? It sits onto a layer, and that allows it to heal. And so this is an angiogram of a right carotid artery. This is the carotid artery. And normally the carotid artery comes up and branches into a middle cerebral artery and an anterior cerebral artery, meaning that is not supposed to be there, okay? Now, the reason we just see the blood vessels is because x-rays usually would show us the bone. And what we do is we do an x-ray and then remove the bone. We use it as a negative, and then we run the film again and inject dye. And in the dye is this radiopaque solution that the x-rays bounce off of. And that's what lets us see the picture for the angiogram. But basically then on the angiogram, we see this thing that looks like a snowman. That should not be there. That's an ICA terminus aneurysm. And so now I'm going to show you how we fix that. And I'm going to show you from a view of us looking basically this way. We come from the top of the head looking down, and we're going to show you this vascular structure and show you how we fix it.
Dr. Snyder?
Yes.
We have some questions regarding what what kind of like leads up to an aneurysm? Like how does the blood vessel get torn? Is there anything that doctors do as a precaution to prevent aneurysms?
So great questions. We know that they can run in families. So there's something genetic about the makeup of the blood vessel that can be off and make somebody very prone. The blood vessels are responding to the mean arterial pressure that your heart puts out, right? So your heart puts out a systolic and a diastolic blood pressure. And the mean of that blood pressure is what's pumping through your blood vessels. And we'll talk about that in a minute. Your blood vessels need to sustain that constant beating and constant pressure for your lifetime. If you have a genetic problem with the makeup of the structure of that muscular component of the wall, it can start to thin and can start to begin the process of forming that pressure-dependent saccular aneurysm. The dissecting can often be from a trauma. You've had some major traumatic event that's caused the minor tear, and then that tear develops as the blood flow pushes its way through it. So there's genetics, there's constant long-term high blood pressure potential issues, there's breakdown of the healing of that vessel, which happens with nicotine or smoking or other facets, and there's trauma. It's a great question. Thank you for asking it. So we are looking right now at the brain, and we're looking at the frontal lobe and the temporal lobe, and we're looking at the fissure between those two lobes. And what I want you to notice is that when we work through that fissure. We don't work through the brain tissue. Brain is that yellowish substance. The blood vessels are small at the surface of the brain and then become very large as we get toward the deeper areas of where they come into the skull. The subarachnoid space is called that because the brain is connected to each other through these wisps of tissue called arachnoid. Those are those white structures that we're cutting in between. And that's where the blood vessels are, and that's where the spinal fluid basically lives. So we're using scissors and tools to pull the brain apart and dissect through the folds of it without going through it. You'll notice that arteries are red. And as we get deeper down, you'll see that veins are blue. The oxygenated blood is red, the deoxygenated is blue, and you can see those. This blue is a vein over here. These are clearly arteries here. We're pulling and slowly cutting each of those arachnoid spaces as we open up the folds of the brain. Again, large vein here, artery here. This is where things start to really get cool or interesting. We've now opened the frontal and temporal lobe up enough that we're starting to get down where the carotid artery comes in. And underneath this wisp is a really important white structure. When you see long white structures, it's usually a nerve. This is the optic nerve. This is the nerve going straight out to your eyeball on the right side. The carotid artery comes in right below the optic nerve. Now, if some of you may have learned in biology or heard about the optic chiasm, that the optic nerves cross. That's exactly what you're seeing in front of you. We're lifting the frontal lobe up and looking at both optic nerves. Here's your right optic nerve. Here's your left optic nerve. They both come together in a cross and sit right below the frontal lobe. We're dissecting all of that away so that we can peel the folds of the brain apart and get down to the base of the carotid artery where it comes in to take care of the aneurysm without having to pull on or tear any brain tissue that might be attached. So all of the microsurgery that's done for an aneurysm is really most of the time spent in dissecting these little wisps of spider web so that everything gets disconnected from itself. And now we're looking at the carotid artery. And here are those two branches I told you, middle cerebral and anterior cerebral. This shouldn't be there. So before we start to secure the aneurysm, the first thing we do is we shut the blood supply coming from the heart up to the head off so that if we rupture it or pop it, we don't have blood spewing out of it. So that's a temporary clip. This is the aneurysm clip going in to get the little bleb behind and in front, including that white. That whole structure is the aneurysm that I showed you before. And so that clip right now, when we look, has secured the back bleb of the aneurysm and the front bleb of the aneurysm so that that's removed from the circulation. Then we take the temporary clip off so that blood's restored. And then we've got this really cool technology. You can inject fluorescence into the dye so that only the blood vessels that are getting flow light up. And you see how that aneurysm is dark? That's how we know we've removed it from the circulation. If we saw bright into that aneurysm, we'd know we don't have the neck secured and dye was getting into it. That's the tried and true method that we've used for many, many years of fixing aneurysms. A part of the problem of that is not everybody can undergo the 4 to 6 hour surgery. Not everybody is healthy enough to undergo general anesthesia. And not every aneurysm is amenable to that type of surgical treatment. So what else do we do? This is what endovascular surgery is. It's going into a blood vessel in the body, navigating through glorified plumbing your way up into the head, and using small wires and tubes under X-ray to do various things. It could be to open up a stenosis. In this case, we're going to talk about fixing aneurysms. So rather than open up somebody's head in this case, we find an aneurysm similarly, this bleb that's coming off the basilar artery, and with wires and tubes, we basically go into it and fill it in with a substance so that that causes the blood to stagnate and it causes that to actually thrombose and shut itself off. That's what endovascular surgery is. And in the past 5 years to 10 years, there have been revolutions in what we can do to treat aneurysms inside the brain. One of which is called flow diversion. What was designed was a fine mesh stent. Do you see this stent right here compared to this stent? This is the typical type of stent of what we put in. It looks like a chicken wire mesh. Do you see how fine the braid is on this stent? By using a very fine cloth mesh, we actually can put it inside a blood vessel if this is the aneurysm. And what happens is that not only does it direct more flow through the blood vessel, but the unique thing that we never expected happens. The endothelium of the blood vessel is living. It uses this stent as a scaffold, and it starts to walk along it. And what happens over a period of months is that the body rebuilds its own blood vessel from the inside out. And so what we're finding is by putting a scaffold in place, we can use the body's inherent healing ability to actually seal these aneurysms off. And that is the body fixing itself. So we've not only worked from outside the main pipe of where the aneurysm is, but we've also built some endosaccular devices that can go inside, again, to seal the neck of where that works. And again, the way this works is it's glorified plumbing. We would bring small wires and tubes. Here's our giant aneurysm right here. Part of the problem is the heart's pumping so much flow. Often the wires and tubes want to go here. It's a trick to get beyond it. And sometimes we loop within it to then get beyond it. Then we actually, from within the tube, can deliver the devices that we're talking about. They're wrapped up and packaged so that they're delivered inside the devices that we're working in. And that's how we would seal off that segment. And again, that's revolutionized how we work. We built a X-ray machine that gives us ultra-fine resolution to see. We almost think about this as operating with the surgical microscope now in the open world. The current X-ray technology, normally we wouldn't be able to see any of these braids, but here at the Jacobs Institute with Canon, we built this basically super X-ray that gives us the ability to precisely put these stents and these coils into place. To show you how dramatic the results can be, this is a holocarotid aneurysm. The entire tubing of the carotid is blown out. When we put a pipeline into the parent vessel, look what it looks like in 3 to 6 months. The entire segment reheals itself and regrows, right? This is another segment of a very sick, blown out aneurysm. And with a little coil and a pipeline, it's rescaffolded and rebuilt itself. This is an aneurysm where we put one of those special endosaccular devices in, and you can see the aneurysm's gone. So in terms of innovation and engineering and design, even though these are still what I call dumb devices, they're just nickel cobalt, or they're mechanical. Imagine if we could start to put some smart things within them, like pressure sensors inside the coils, things like that, where you're now monitoring these for longer term for someone's life in case they ever came back. We have yet to start to innovate and put new smart things that might communicate wirelessly into these and implant into these devices. But that said, we're now able to treat aneurysms, which we never were able to treat before. These are some examples of the 3D anatomy that we're able to use, and including that simulator that I brought up before. We're also doing virtual reality training and simulation from those at the JI. So I thought that would be a good section to start with before we jumped into physiology, just to show you how much innovation there can be from the people that are, engineering based and designed, very mechanical based and designed, to how much that can impact our ability to care for patients and offer treatments and surgeries that were never available even just years prior to this. Any questions at all about aneurysm basics or aneurysm treatment, open surgery, or endovascular?
Yes, Dr. Snyder, we have a few different questions. So our first question is, how long can aneurysms go untreated before a patient dies from it?
So that's a great question. And part of that problem is we don't know how fast they've grown. We have snapshots in time. There was a landmark study that looked at the sizes of aneurysms and their risks of rupture over time. And what it used to basically tell us is that if somebody has an aneurysm or a bleb that's more than 7 millimeters, let's call it 10 millimeters in size, that they may have a risk of rupturing of 1% to 2% per year. Now, if you're 40 years of age, that 1% to 2% per year is very significant over your future lifetime. Right? If you're 85 years old, that may not be as significant because there's a risk of actually doing the procedure. One of my co-fellows, who's now the head of cerebrovascular down in Mount Sinai, did an amazing study during our fellowship. What he said was, why would the size alone be important in terms of the rupture? Wouldn't the size relative to the size of the vessel coming off of it be very important? Meaning if the artery is 6 millimeters and the aneurysm is 6 millimeters, does that behave the same way as if the blood vessel was 1 millimeter and the aneurysm is 6 millimeters? So he actually, while he was with Buffalo, we did a study and showed that the size ratio is very significant for the rupture risk also. The other important part about aneurysm surgery is this: you only get one chance to fix them before they rupture. If they ever rupture, 2 out of 3 people are dead almost immediately. Blood is pouring out into your skull or head. Your pressure goes up. Someone drifts off to sleep almost immediately as the brain does what's called herniates. There's not room for that blood into your head. And so it pushes the brain downward through the hole in your skull called the foramen magnum. And that's how people pass away. The only way to survive a ruptured aneurysm is that the body can't pump any more blood into your head, meaning the pressure and the pressure in the head have equilibrated, and we're lucky enough to form a clot. What that means is whoever survived a ruptured aneurysm has survived the worst possible potential pressure headache they could ever have, and it's often why there's so many cognitive consequences. So we have a very low threshold of treating them when we find them, even if they're small. Things that we look for are, is there a secondary bleb? Did it become like a snow? It started as a spherical shape and now there's a second little weakening within that. Those are high risk features. We also have a bunch of fluid dynamic experts that look at all these aneurysms that we generate and try and help us develop rupture strategies and risks from those. So there's a lot of great work that goes into it. Basically, from our standpoint, we have a low threshold when we find them to fix them because we want to fix them before they've ruptured.
We also have some questions about like the surgery itself. Is the patient awake for the surgery? How long does the surgery take? Some things that can go wrong.
Great questions. So the risk of complication from the surgeries are on the order of about 3%, and it's different depending on the type of surgery. Whenever you do an open surgery, the risks can be infection, they could be spinal fluid leak, they could be bleeding and need to go back in. Often when the head's open, the risk of the aneurysm rupturing is less of a concern because if it bleeds, you're right there to fix it and the blood comes out of the head. It's not filling the head if the skull was closed. Patients are, the vast majority, asleep for the open surgeries. But I will tell you, we do awake craniotomies, and there are people, and we can do awake surgeries for aneurysm clipping. We numb the entire skull completely, put somebody out through anesthesia, remove the bone. When we do the intricate work, we could wake somebody up and be talking to them and examine them. When you're working through the brain itself, there aren't any pain nerve endings down in there. So no one's in pain or discomfort when you do that level of work. So we often do more awake surgeries for tumors, but we can do them for aneurysms. When we do endovascular, someone's completely awake. They're given a little bit of sedation, but we actually like that because it gives us a constant ability to make sure they're doing okay. Our biggest concern with either surgery is causing a stroke, blocking off one of the main blood vessels that goes to a different part of the brain and causing an ischemic stroke or damage. Great questions.
We have a few more different questions. So regarding, sorry. Oh, how often do aneurysms come back? You mentioned that sometimes these devices help prevent or with that. How often could they come back?
It's a great question. And I think it comes down to how well we rebuild the endothelial layer again. So here's my example. So if we have a problem of this aneurysm, and if we go up with our wires and tubes and we what happens over the next 5-10 years is the blood pressure is still pounding into this. And so what can happen in 5 years is that starts to look like this, where the coils get compacted and the base refills as an open aneurysm, and we might need to go back in and coil that off. What's helped us with that is these endosaccular devices that seal at the neck, allowing the body to re-endothelialize. So we've had less recanalization with that type of technique, right? Same issue with these sidewall tearing aneurysms. They're called pseudoaneurysms. If we have an aneurysm coming off the side of a blood vessel, which is odd, it's usually because there's a tear there. And if we go in and we just fix this part of the blood of the aneurysm, what happens in time is that aneurysm pulls away further from the wall itself because that's where the problem is. That's what's awesome about these flow diverting stents. These flow diverting stents allow the body to walk and seal over the area where the tear is, and those are giving us longer term solutions. So again, what we've learned is use the body as much as you can to help heal itself, okay? That doesn't mean that somebody that has an aneurysm can't develop one somewhere else. They usually have that underlying genetic issue or problem there. And so you've got to be watching these people for life for new aneurysms to develop elsewhere.
We also have some questions about, yes. We also have some questions about some of the devices that you mentioned earlier, like how do you know how to direct the device in the blood vessel, how to like apply it, things like that, just kind of more information on the transmitters and devices used.
Sure, great questions. So we often, the wires that we use to navigate the blood vessels, we often shape into a small hook. And the wire is so long, it goes from the head all the way out the leg in the body. Our surgical work is done by holding the bottom end of this wire and twisting and turning it. You can imagine how much friction and problems build up with all of the turns that have to happen through the body to get there. So one of the main things surgically that we deal with is the inertia of that difficulty of needing to move sub-millimeter here with all of the momentum and issues of the wire going from the leg around the arch into the neck and up into the head. We then have these, again, tubes that we have control over that we can be pushing back and forth. Once we get the tube into place, it's literally by putting a coil through this, we're feeling every aspect of what that feels like as we're releasing it into place. So that's where the surgical technique comes in. We are working on how do we use a robot to enhance us, to be a better sensor for us. Just like you turn the feedback up or off on a force feedback joystick, can we work with improved sensation feedback in the head to give better sensitivity? Huge area of research and opportunity for us. Great question.
We also have some questions about how do you recognize that someone has an aneurysm? Like, is there like appearance, something changing their appearance?
Right. No. So again, unfortunately, it's usually found by some form of headache workup. Somebody has either a neurologic symptom, which could be focal. They may have a dilation in one of their eyeballs. They may be developing a problem with their face or somewhere, and we do imaging and find it. Often it's from headache, or we do screening imaging of blood vessels for families that have generations of aneurysm within them. And then sad how many we find within them. So again, we know that there's that genetic component of it. But basically, if you have a strong family history and you're older than 20 years of age, every 5 years we scan your blood vessels to make sure that you don't have one.
Okay. Sorry.
No, please.
We had another question. How do you, when clipping an aneurysm, how do you know which clip to use, or like how do you know which technique you want to use for a specific aneurysm?
Yeah, great questions. Often we try and match the tool to what we see. Okay, so for example, if I'm clipping an aneurysm and the aneurysm looks like this and the main pipe might be complex, I might use a clip that has an angle just like this so that when it comes down, it matches perfectly along the parent blood vessel. And the clips come in straight, they come in hooked, they come in right angles. So the idea is and they also kind of come fenestrated, some with the loop, so that if I have an important blood vessel that has to come through out at me, and the aneurysm I want to clip is here, I'm able to accommodate almost any geometry that I see. There are also some times that we are treating a giant aneurysm and we actually just put clips all the way along it like a picket fence to shut it off as well. Sometimes these are very heavily calcified and we need to actually pop the aneurysm to get the blood out first before we put clips down. So there's all kinds of tools and techniques. Same thing with endovascular. If you have an aneurysm that you're going to fix that looks like this, it's a little small hole, it's going to hold a coil much easier than an aneurysm that looks like this. Because if you try and put coils into this, it's just going to blow out into the parent vessel and cause an obstruction or a blockage somewhere down, and that's how you can get strokes. So often if we're going to fix something like that, we actually put a stent, and then sometimes through the stent go in and put a coil in. That's what's called the stent coil. So we've got all kinds of neat little cool tools that we can use depending on the geometry of what we want to solve. And the tools keep getting better. In 10 minutes, I want to cover an important principle of physiology to set us up for next session's stroke imaging coverage, okay? Mm-hmm. And that's this. Prior to 2 years ago, if any of you or your loved ones woke up with a stroke, there would have been no treatment for you. The American Heart and the American Stroke Guideline for the treatment of stroke was that you must know the time of onset to be eligible for a clot-busting drug. Think about that. Does that? And so 10 years ago in Buffalo, we said, this is crazy. We've got to find a way to look at if the brain tissue is alive or dead. Why are we worrying about time? Because certain people may be able to keep their brain tissue viable for much longer. And if the brain tissue is alive, I'm going to go up and try and take a clot out. Does that make sense? That basic question 10 years ago has transformed how we treat stroke today. We now use imaging of the brain to assess if the brain tissue is viable to decide if you can treat someone's stroke or not. And it's become a standard and guideline now for the entire world and country. That did not exist before. And I will tell you that we in Buffalo did a lot of work to get us to that aspect. And it all came from the simple question of, why are we just using time to do this? One thing, no matter what aspect of medicine that you go into, to help give you a good breadth or understanding of how treatments are done, are to look up what are called guidelines. So these are stroke guidelines. And guidelines aren't a rule book that means you have to do it every time. Clinical judgment is, if you don't think the guideline fits, you don't do it. But it's nice to know what, I use an 80-20 rule. 80% of the time, I usually end up following the guideline, 20% I don't, and then I document why I don't, okay? But what's beautiful about the guidelines is it's got all the literature that helped build that guideline for its treatment. And so it's a good place to begin. And again, what I love about the 2018 and 19 update and guidelines is finally physiologic imaging of the brain to treat stroke is now our standard of care. So it's, again, pretty cool that wasn't there when I did my fellowship. It's pretty cool to have been part of a field that has changed its treatment that you've been involved in and watching develop. So part of the way I think to set ourselves up for understanding physiologic imaging is to understand just how amazing the brain is. Okay, and I'll talk about blood supply in general, and I'm going to talk about something called an arterial venous malformation to teach us something. And then we'll take some final questions and call it. So the heart is down here, and 20% of the cardiac output comes up the carotid arteries straight up to the brain. There's 2 carotid arteries in front, and in the back, there's 2 vertebral arteries. This person only has 1 vertebral artery, and the carotid arteries come straight up into the brain. And then in the brain itself, they interact and communicate with each other, called the circle of Willis, where the carotids and the posterior circulation interact with one another. The carotid artery itself comes up into the neck as a pipe and branches into an external that goes to your face and an internal that goes straight to your head. The internal has no branches to it whatsoever. The external has all these branches, one that go to the tongue, one that go to the other facial muscles, et cetera, et cetera. All of the external branches behave just like every other blood vessel in your entire body. And so for a minute, I'm going to pretend to be a Doppler of the external carotid artery. A Doppler is something that transmits flow into sound. You've heard of kind of the Doppler shift that can occur when an ambulance or something goes by you. This is similar, but a Doppler takes flow and turns it into sound. That is going to be similar in sound to every other blood vessel in your entire body. And it sounds like this. There's a high-pitched sound, and then there's silence. The reason there's silence is because the heart is filling and relaxing. So when the heart beats and drives up its pressure, the pressure reaches high enough to push flow through the resistance of this blood vessel supply, and you get pulsatile arterial flow. So our entire body gets flow in a pulsatile fashion. Does that make sense? Again, at some point, these arterioles go down to small capillaries, which are where the high resistance is. And it's that resistivity that determines whether or not there's any further flow. Once the pressure gets below that resistance, the flow stops. The heart gets flow reverse. When it's pumping, it's high resistance. When it's relaxing, it gets its flow. So if the body gets, the heart gets, all right, but it's still pulsatile. Here's what's really cool. If you are a Doppler of the internal carotid artery, this is what you sound like. Think about that for 1 second. Even while the heart is filling and relaxing, you have constant forward flow to your brain. How cool is that? We have no idea how that occurs. There must be elastic energy stored within the walls of the blood vessel itself, such that even when there's no pressure head, you still have flow flowing through and up to your brain. Here's another really important thing. If your blood pressure was 200 over 120 or 90 over 40, the flow to your brain is the same. It's called the Monroe-Kelly doctrine. So if we were looking at pressure and flow, there's a diagram that looks like this. Actually, this way. Pressure, flow. If your blood pressure is super high or low within this range, the flow to your brain is the same. Once your blood pressure gets much higher than that, you can start to have increasing flow and you often generate headaches. It means your body has the ability to regulate the capillaries and control the resistance. It's going to reduce the capillaries or bring the resistance higher if your pressure gets up to keep the flow the same. And then it can only squeeze so tight, and then the pressure can overcome it. And if you come back this way, it's going to dilate the blood vessels, make them so the resistance is smaller and smaller. But at a certain point, even when the capillaries are fully dilated, if your blood pressure is too low, you're not getting any flow to your brain. Does that make sense? This physiology is why we argued so much that we're smarter than a stopwatch to treat stroke, because the brain can regulate itself for significant periods of time. The brain can draw blood where it needs it for significant periods of time. For the next, we'll try and do, how are we doing time frame wise? 2 minutes?
Yes.
I'll end with one comment. We'll come back and begin with this. This is what a normal arterial supply looks like anywhere in the body. Arteries are like raging rivers. They trickle down to a capillary bed that's like a stream. This is where all the money is. This is where all the nutrients get exchanged and waste products are picked up. This is what's key to sustaining tissue. And then low pressure, deoxygenated blood goes into the veins. These are like the lakes. So raging river, stream, lake, artery, capillary, vein. Does that make sense? The capillary size and diameter affects the resistance, which affects how fast the water flows through those segments. Again, does that make sense? There are blood vessel tumors called AVMs where they don't make the capillary bed right. The capillaries are made as these giant structures. They never work right. And so what happens is the raging river rushes through to the vein. And the veins aren't meant to deal with that type of high pressure flow. And so what happens is you end up with these tangles of blood vessels inside the brain itself. If you don't make capillaries appropriately, what else can you not sustain? What is not inside this AVM because it doesn't have normal capillaries? Normal brain tissue. There's no tissue. Without the ability to exchange nutrients, you can't sustain tissue. So all that's left inside this is this tangle of blood vessels. Does that make sense? All right, we're going to start next week with an understanding of this. If you have a big artery coming up that feeds normal brain or feeds no resistance AVM, where do you think all the blood wants to go? To the high resistance capillary bed or to the zero resistance AVM? You've got water flowing. There's resistance here and no resistance here. It's going to all go here. And so what happens is that normal brain starts to become ischemic because you're shunting blood to this area with no resistance. In fact, this then goes to the vein and back to the heart. Children die from this disease from congestive heart failure because all they're doing is pumping blood up to their head and down to their heart and up to their head and down to their heart. It's not going to normal areas. There's this low resistance loop. This is important because if we have the ability to adjust the resistance of areas, we can decide where and how blood goes to different parts of the brain. Okay? Any questions that came through? Otherwise, we'll pick up here on Friday and we'll take this concept into stroke. But Sarah, do you have anything that you want to end with? Any questions?
Yeah, there's one question. If one blood vessel that is connected from your brain to your mouth and that vessel stops working, does that mean that your mouth would stop working?
So the blood vessel goes to the health of the tissue. So what would happen is if, and this happens because I fix, like say, really bad nosebleeds, all right? And I want to stop the blood from pouring out of the nose. I have to do that by building a dam proximal to where the nose is. So if these are the blood vessels that go to the nose, I stop the blood flow here. If I ever stop the blood flow in the tissue necroses and loses itself. So what would happen is the nose would literally turn black and fall off. So when we talk about the blood supply keeps the tissue healthy. Now, there are nerves that travel to that area and also interact with it. Those nerves do get a little bit of blood supply. The nerves are the electrical cabling that make the face move. So if I have a nerve that's crushed somewhere else, either coming off the brain or along its pathway, or the nerve has lost its blood supply, that's when you can lose function, or at the origin in the brain of where that nerve is generated.
Thank you so much, Dr. Snyder, for these webinars, for today's session.
All right, I'll try and stop a little earlier next time, and then we'll pick up with this concept of differential blood supply to resistance, because that's the key to understanding how we do physiologic imaging for stroke, and then we'll dive into COVID after that.
Sounds great. And just a reminder that this webinar session was actually recorded and will be posted to the JI's YouTube channel shortly. Thank you again, Dr. Ken Snyder.
Thank you, panelists. Thanks, Sarah. Appreciate everybody's time. See you. Talk to you on Friday.
Have a nice night, everyone.